By the way, are you going to record? No, you are recording. Are we going to see your picture tonight?
It's up there.
No, all I see is the answer cancer screen.
Well, my video is on.
Okay, maybe it's something that I did wrong.
Nope, I've got him, Jake. I can see him.
Okay. Hi, Rich. Can you see me now?
Let's see. Let me get that out of the
Yep,
way.
you're in there.
Yep, you're
Okay.
there.
I can see you now.
Well, I must have done something.
I can see you, Jake.
Okay.
I can
Then
see Rick.
Okay, and Gary.
Yep, I'm here.
Hey, Gary.
I see. We were just taking your name in vain. We love to.
His ears were burning. That's why he had to call in.
That's right.
Well, you know, the hockey, you know, it's hockey time right now, so it's kind of stressful right now. So.
Oh no, I got that covered. I got a 27-inch IMAX sitting next to a 42-inch Vizio.
Well,
I will alter the volume as necessary.
And we know who you're following, Rich Jackson. But what about Gary? Gary, who are you? Are you a Las Vegas night?
Yeah, let's see if I can put on my cam. Let's see.
I can see you, Gary.
Stanley Cup
Golden Knights.
Finals.
The Knights, go!
What do you mean, go Knights, go? They weren't around last year. Since all of a sudden, you know, a newbie.
Well, that's the classic. Is these are the cast-offs from all of the established teams.
That's right.
These are the leftovers.
Right.
They have got a chip on their shoulder like you wouldn't believe. Fire
You know
me,
what?
I'll show you.
Yes, that describes me to a T. Chip on the shoulder. There you go.
We knew that.
Okay. Well, let me ask you. Before last season, who were you following, Gary?
I never followed anybody, but I went to Las Vegas to visit my sister, and we went to a hockey game. So now I'm a Knights fan.
Oh, excuse me.
Uh-huh.
Now I understand. I got it. Now I got it. Okay. All right. We have a few people on the telephone. Anybody like to pipe up? Tell us who you are.
Good evening, everybody. This is Sylvester.
Thank you, Sylvester.
Hi,
Number
Sylvester.
5.
Hey, Sylvester, number 5, right, Rick?
Yeah, number 5 for Sylvester. And who else is on the phone that hasn't identified? That would like
Jay Mills.
Jay Mills, number 3. Hello, Jay.
Hey.
Got it.
Been thinking about you. I'm wondering what you've decided to do. So we'll touch base with that one. Yeah, number 3 is Jay Mills. And then we have one other person on the telephone who is not yet identified. If you'd like to, that would be fine. If you prefer not to, that's okay too. Okay. Ah, and Professor Bill, Jim McCoy, you're in luck. Professor.
All right.
Professor Bill is on the call as well.
Excellent.
There you go.
Oh, hey, Jim, did I responded to you
You did.
earlier today, right?
Yes, you
Yes.
did.
Yeah, okay,
Yes.
good.
Thank you. And I'm just listening to your talk last one of these calls,
Okay,
the recording.
great.
Yeah.
But we should talk on the phone though too.
Oh, absolutely. We could hog this call. I won't do that.
Okay. And Bill Franklin just came in. And Brian Heisey just came in.
Wow.
Okay.
So no new names then anyway. So I was wrong about the turnout.
Well, we've got one person that may be a new name but hasn't told us yet. But what we I should let if the caller is a new name, we usually give new people a space at the beginning of the call to tell us a little bit about their situation, their disease, and to ask any questions. We spend maybe the first 20 minutes to half an hour. So I'm just going to go through I'll go through the roll and then see if I've got everybody, and then we'll go from there. So I see Jake. I see Dennis Correa, who's enjoying 106-degree Fahrenheit temperatures. Correct, Dennis Correa?
Beautiful day. Had a nice round of golf today.
Yeah, me too. I went to Patagonia Lake and Road this morning before it got too hot. I think it was only 90-something when I came off the water. So Jeff Marchi, welcome back. Jim McCoy, Rich Jackson, Larry Fish, Gary Gunville, Peter Kafka, Bill Burhans, Bill Franklin, Brian Heisey. Have I missed anybody?
Sylvester?
Sylvester! Oh, thank you, Sylvester. Oh my gosh, Sylvester.
Cannot forget Sylvester.
Thanks for keeping me in the loop.
We love you, Sylvester.
We do.
Okay, so yeah. So let me go down the list. I may just elevate some. Oh, and I meant to call and I forgot. I haven't heard from Eric since the surgery. He did contact me the morning of the surgery. I wrote him back, and I meant to call him today so I could give you guys a report, and I didn't do that. I apologize, but I'll call him either after the call or later. I did text him, but I didn't hear back, so I don't know I don't know where we are. Okay, Jake, anything for you today?
No, Rick.
Okay. Dennis Correa, ×2.
Just listening in tonight. Just listening in, Rick.
Just listening in. Are both of you just listening in, or is one of you going to ask a question and the other not?
Yeah, you have to ask him twice. You have to call him twice.
I have to ask him twice. Okay. I asked him twice. He didn't answer the second time, so I guess both the Dennis Correas are just listening in, so that's okay. Okay. That's because it's so hot in Tucson, it takes too much energy to speak right now. I know how it is. Jeff Marchi, anything for you tonight, sir?
I could make just a quick comment about something.
Okay. I just saw a couple of other people that joined us. Jim McCoy, should we talk? Why don't we have a limited discussion, and then we can pick that discussion up a little bit later about your BRCA issues.
Well, thank you. Actually, everything is in abeyance right now. I'm in the process of getting the UCSF 500.
Right. We'll come back to you, Jim. I'm just sort of marking up who wants, who has something to talk about, and I know you do. And then we'll run down the list, and we'll definitely talk to you a little bit about that.
Okay.
Rich Jackson, in between periods, is there anything that you'd like to say?
At the moment, I'll just lurk in the background.
Okay. All right. Larry Fish, anything for you?
Hi, I'm okay, thanks.
Good. Okay. Gary, anything for you in between periods?
Yeah, I could share what my meeting was like with the radiation.
Oh yeah, please do. Please do. Peter.
Yes, I've got some question about something that makes to no end, and I wouldn't mind Bill and perhaps yourself or anyone else who might be able to shed some light on it, help me out.
Absolutely. And Professor Bill, I know that you've got a fascinating update to tell people, so we're going to put you in.
I'll keep it far less than 40 minutes.
Okay.
How long I took the last one?
Okay. And Bill Franklin, hi. How hot is it in in Florida?
No, it's not that bad. It was in the high 80s today, but it's humid as hell. It feels like it's 100 degrees.
Yeah, our humidity hopefully doesn't start for about another month. Anything you'd like to talk about?
No, I'll just listen in tonight.
Okay. Brian Ivey, what happened to the Cubbies?
But they're on a roll.
They are going to roll, or they have rolled over. I'm not sure which.
No, they've been doing pretty well lately.
Okay. Sorry, I'm not up to date. Okay,
Uh-oh.
They're on a roll. Okay. Anything that you'd like to talk to us about?
Nothing today, thank you.
Okay. Sylvester, anything you'd like to talk to us about?
No, thank you.
Okay. Jay, would you like to update us on where you are in your process? Jay? Maybe it doesn't look like you're muted. Oh, you may be muted at your end. No. Well, we'll come back to Jay. Jay Mills? Okay, we'll come back
yes.
to
Yeah, I'm here.
Oh, there you are.
Okay.
Okay. Would you like to update us on where you are in your process when we come to you?
I could do that. Yeah, sure.
Okay. I see Les Shelder. I know you've been on the call before because I remember the name, but not for a while. Would you like to give us an update? Les Shelder. Are you there? Maybe another person who's buried in the hockey playoffs. All right, we'll come back to Les. I'll touch base with Les again. Maybe Jay, Jake, would you mind just sending Les a little note and asking him if there's anything he'd like to talk about? Because we're not getting through to him.
Will do.
And thank you. And I think that's covered everybody.
No, you missed me, Paul Freedom.
Oh, Paul Frieda. Oh my gosh.
I got a couple of questions.
And you had a couple of questions. I'll tell you what. Since I missed you, and since you were here first, we're going to kick off with you.
Okay.
With your couple of questions. Go for it.
Okay. First one is, when is it advisable to do the DNA testing? Is it you should do it as soon as possible, or you should wait until a certain point in your process, or what?
So, are you going to ask us both questions at the same time, or are we going to?
No, I'll do one at a time. One at a time.
One at a time. Okay. Well, the first answer to that is what we've discussed here very frequently, Paul, which is that you have to discern which DNA testing you're talking about. There are two different types of DNA tests.
Right. One is somatic, and the other one is what is it? What's the other one called?
Germline.
Germline, right?
Germline. So the germline tests for inherited mutations, and so you can do that anytime.
Okay.
Because if you've got a germline mutation, it's been there all your life. And it's just a question of discerning it and uncovering it. And that's how Bill, who I'll bring in a moment, found out that he had a BRCA mutation, was through the germline testing. Now, oftentimes there will be clues in your family's health history that that you may have some sort of inherited mutation. As Bill will tell you, there was a heck of a lot of cancer in his family, and that was a good clue to do a germline test. The tougher question is when to do a somatic test. And it gets even more complicated, or there are more considerations, because Medicare, in approving somatic testing, only allows you one test lifetime, which is something that we're trying to change, and we objected to when they wrote the approvals, and it may well get changed. But right now, it's only one time. It's only a one-time approval. That's not to say you couldn't do it a second time and work out a deal with whoever's doing the testing, and you may well be able to do that. So, since I've covered the financial part, I'm going to throw this off to Professor Bill to talk about when the right time is to test. Is that okay, Professor?
Sure. Yeah. What are you throwing off to me?
Well, the question that Paul has is, when should I test? When should I do DNA testing? And as I've said, and as you'll tell people, you and Peter have all done germline tests, and you've all found something through the germline tests.
Yeah. Okay. So, Paul, the guidelines used to be that you should do the germline testing if you have an extensive family history of cancer, and that's something that normally you would visit with a genetics counselor to discuss, and they would make a recommendation on whether or not it was worthwhile to be tested. And then, eventually you would get a referral, and you'd have to send a sample of blood or saliva off to a company that does the test. But in the last couple of years, there have been a couple of reports that suggest that anyone with metastatic prostate cancer should get a germline test, because the frequency is actually quite high. The odds are quite high that you will test positive. So my recommendation would be to speak with a genetics counselor and tell them. So, do you have metastatic disease at this point?
No, I'm in remission with Lupron right now, 2.5 years.
Okay, so if you're not metastatic yet, I would talk to a genetics counselor, and be prepared to go over your family history with them. Try to collect as much of that sort of information as you can, and then follow their recommendation. If at some point you become metastatic in the future, then there's no doubt that you should be tested at that point.
And the result of the test will alter your treatment?
Yes, very much so. It could. I mean, not always, but there's a good possibility that it would. If you test positive, then you become a candidate for a whole class of drugs that, interact with mutations in what are called DNA repair pathways that can be quite effective. So in my case, that's because of the mutation in BRCA2 that we discovered in my germline. I was treated with a drug called a PARP inhibitor, and I was given a very poor prognosis, and here I am 3 years later, still alive and kicking.
Well,
So
the idea, the mutation has caused our prostate cancer?
Yeah, that's exactly it.
I see. Okay.
Yeah, in my case, there's no doubt about it. I mean, you can't always, it's always, it's difficult to determine cause and effect, and so it's not always as straightforward as it is in my case. But in my case, there was such an extensive history of cancer that is caused by this particular mutation. So ovarian, breast cancer, pancreatic cancer, melanoma, that there's no doubt that it played an important role and probably was a causative factor in my disease. So that's, hi Len. So that's the scoop on germline testing. In the case of somatic testing, anyone with advanced prostate cancer should also be tested, should, have their tumor DNA tested for mutations. But as Rick pointed out, it's a little bit trickier here because you may only have one shot at payment for it. So that's something to consider. And it's also the case that you need material to recover DNA from to sequence. And that can be difficult. If you ideally, you would find a metastatic lesion that you could recover enough cells from to purify DNA and sequence. That can be difficult, especially if the lesions are in your musculoskeletal system. It's difficult to biopsy bone. But if you have a lymph node with metastatic disease in it, that would be a good source of material. And then it's also possible to have something called a liquid biopsy, which involves recovering either tumor cells or tumor cell DNA from your circulatory system and sequencing that. But there aren't very many companies or organizations that do that type of testing, so that can be difficult to obtain. But in any case, I think, if I were you, I would be, if you're not metastatic, I don't think you need to worry about the somatic cell testing at the moment. And I would definitely talk to a genetics counselor if you have any kind of family history of cancer to discuss the possibility of germline testing.
I mean, just one person in your family, that would be enough, or do you need 2 or 3 or something like that?
It's really, this is what genetics counselors are trained to assess. Your risk for prostate cancer is elevated if you have one first-degree relative, as few as one first-degree relative with prostate cancer, so a sibling or your dad, for example. Your risk is elevated if there is a history of breast cancer in your family among first-degree relatives, your parents, siblings. The same with ovarian cancer. But exactly what point the risk becomes high enough to warrant germline testing really is it can be a tricky call. And so the best thing to do would be, if there are others in your family that have these types of cancer, then, I would make an appointment with a genetics counselor and get their opinion.
Okay. All right. Thank you very much.
Sure.
So just a couple of things I'd like to add. The first is that there are several companies out there like Ambry and Color and a couple of others that are doing germline testing. And you can go directly to some of these companies, and they actually will refer. I don't think they require genetic counseling, but if you go through a medical facility, genetic counseling is required. Color will refer you to a genetic counselor. They have genetic counselors that they work with. So, so if you were to use Color, you could definitely find a genetic counselor. I don't know about Ambry. I think Peter used Ambry, but he did it through UCSF, so he spoke to their genetic counselor there. The other thing that
Before you go on, Rick, let me just say that you can go, any of these companies would be happy to do the test as long as they get paid for it, and they don't care who pays for it. But if you want your insurance to pay for it, you have to go through a genetics counselor, and you need a referral from a genetics counselor.
Okay, that's a really good point. The color test is about $250 if you're not getting reimbursed. Now, the other point that I wanted to raise with Bill, and we've had this discussion, but it's a good one, and so it's a good refresher, is there is a significant difference in when you do your somatic testing. There is a difference in the cells that are in the primary tumor. So some of you may have an intact prostate gland that could be sampled versus the metastasized cells that are forming distant lesions. Bill, can you just talk about that a little bit, and in your opinion, you know, should you be analyzing a distant cell rather than the primary tumor?
Yes, that's preferable because the genetic makeup of metastatic tumors is more homogeneous, and so you get a more accurate snapshot of you know what the mutations are that you're dealing with. Especially, you know, it's the metastatic lesions that kill you, not the primary. But you can go to the primary. You can recover material from the primary tumor, but it's usually not as informative as the material from a metastatic lesion.
Thanks, Bill.
This is Jake.
Yeah.
Can I ask a question? We're talking something totally different than the Foundation one and those kinds of tests that we discussed here before? We're talking about something totally different?
No, not at all.
Exactly the same.
Oh, okay. Well, what is Foundation one? Is it a germline or a somatic?
Somatic.
Yeah, they only do somatic. But other companies like Ambry that Rick mentioned will do germline testing. There are a number of companies, and that actually, Paul, this is something to be aware of. This is turning into a big business, and there are a lot of new companies coming, on board to do this type of testing, and they have varying degrees of expertise and competence. And so, you want to find a company that has a good, solid track record. Ambry is one, but there are other considerations too, including how many genes they're going to test for mutations. And generally, the more they test, the better, because you're more likely to find mutations that can be, useful in terms of of designing a treatment strategy.
And
So,
that applies to both somatic and germline?
I'm sorry?
That applies to both the dramatic and
Yeah,
Yes.
somatic and germline.
Yeah.
Number of genes tested, yeah.
right.
Yeah. Peter, did you want to add anything to this discussion?
No, I think we covered pretty much all of it. I think the day's going to come when it'll be automatic with any kind of, particularly with prostatectomies. You know, now with women being urged to test do genetic testing for breast cancer, I think it's going to become commonplace before too long. I bet.
I think you're right, Peter, and I think that's good. I think it's, you know, it will. I think what will happen in the not too distant future is anyone who's diagnosed with prostate cancer will be tested, because it's becoming really apparent that mutations in DNA repair pathways in particular just play an enormously important role in, you know, a large fraction of all prostate tumors. And so, yeah, I think that's where things are headed.
Does anybody else have any questions that they would like to ask on this subject of somatic versus germline?
This is Bill Franklin. I just wanted to make a comment. I think the last couple of comments about this becoming a standard, doesn't this tie into the metastatic prostate cancer research project that we discussed a few weeks back, or I don't think it was a month or so ago, right?
Yeah, no, it does.
Yeah, I signed up for that, by the way. I don't know if anybody else on the call did.
Yeah, I did. I did, Bill.
Good. Yeah, I would encourage everybody to sign up for it.
Yeah, the last thing I heard was they were going to contact my hospital and my doctor to get a sample of my tumor tissue and everything. So they sent the the spit collection thing, and
Right.
I had germline testing through Moffitt Cancer Center at Tampa anyway, just to see what was going on, and I was negative for all of the mutations that were looked for prostate cancer. So, you know.
Yeah, now it's germline testing.
Yeah, germline. So.
Yeah.
The only problem with that that blood project is you don't get individualized results.
Yeah, that's true.
They get combined with into a massive database, but you don't get individual to the results like you do with these other ones we're discussing.
But hopefully, in the long run, it helps somebody out.
Right.
Yeah.
I have a question.
Rick, can I just comment on what Bill said? Bill Franklin. Also, you should be getting from the Metastatic Prostate Cancer Project a tube of blood that you'll need to take to a phlebotomist and have them draw your blood. Even though you had it done at Moffitt, they still want their own sample for germline testing. At least that was the case for me. I assume it was for you too, Bill Burns and Jake.
Yep, you're absolutely right.
Yeah, they did not ask me for blood.
You'll get it eventually. It lags a few weeks or a month.
Yeah, for me it was a tube of sputum and then a tube of blood. And I don't know if they ever went and asked my doctor for a tumor sample or not. I don't know about that. They never said anything about it to me.
I got a form letter about it. So
I think that
they will, and I have to do my blood draw.
I'm sorry, I missed that.
Say that again, Peter.
I had to pay about $14.
You're breaking up, Peter.
I said I had to pay about $14 to have my blood drawn for that test, even though it was in conjunction with the draw.
Oh, okay.
Okay, I didn't. That's the first I've heard of that. I was going to say that I signed up, I think about 2 months ago, and they told me they would be in touch, with the details of the blood draw or the spit tube within a couple weeks. and I've yet to hear from them. And I think I'm guessing that it's because there are so many people signing up that there's probably a backlog. So if you don't hear from them right away, I think if you're patient, you eventually will.
I have a question for Bill Franklin. Bill, were you clearly metastatic or not?
No, and that's one of the things they have a questionnaire about your progression and everything. And when I filled out the rising PSA after surgery and gave them the numbers and everything in their questionnaire, and I can't remember the exact wording, but it was like that qualifies you to be in the study. I never had Mets. I just had, my PSA went up pretty fast after surgery.
Okay, well, that's good to know, because that means that, say, somebody like Paul Frieda might also be eligible to throw in a sample. I didn't realize that they were taking people, but that had a rising rising PSA. But we need to move on. Paul, I know you've got another question.
I'll save that for another time. I've taken enough time already.
Yeah, save it, or if we've got time at the end, we'll come back to you.
Okay. Mm-hmm. Thank you very much, everybody.
Pleasure. But I want to segue this into Jim McCoy, because these are issues that Jim McCoy is currently facing. And Jim, you can give us just a quick update on your situation, and then maybe we can elaborate a little bit on the BRCA aspect. Please go ahead. Jim McCoy?
Okay, I'm trying to get my phone to work here. Am I in now? Am I speaking? Can you hear me?
Yep. Yes, we hear you.
Okay. I'm not sure what I can really add at this point. My rising PSA went back down to the detection limit to 0.015 and with one assay and 0.01 at another. UCSF has done my spit test and is just starting the UCSF 500. That's a blood test that I'm guessing, I don't know what, I guess you'd call that a somatic test. And I don't know where I'm at right now. It's that simple. I learned that I'm BRCA2 mutation positive, and the numbers from my study on that in a short period of time say that that's really not so good. That from my completion of primary treatment, where I had a 85% probability of non-recurrence within 5 to 10 years, that 15% recurrence probability goes up by at least 4 to 6 times, which is not a good number. And so I'm just betwixt and between right now, trying to learn more. I was reaching out to Rick and Bill, and hopefully finding an oncologist who speaks BRCA.
And who is your oncologist right now that that you're dealing with at UCSF?
Chuck Ryan is in the process of leaving.
Correct.
But he's not been in this loop at all.
Okay.
Joe Shu, a radiation oncology, I saw a couple of weeks ago, and he gives you a big. He's not a genetics expert.
No, correct.
He's just pretty much not relevant. He's a treater. Did a fine job with the HDR. The Malika Dewan in the Hereditary Cancer Center who is the investigational therapeutics oncologist, just rudely went off and had a baby. And so she's pretty much out of commission, but through email, I've been pressing her to link me to Felix Feng, who's...
Yeah, you don't want to see Felix. When I say you don't want to see Felix, he's a great guy. He's very smart, but he's another radiation oncologist. So the man I would recommend that you see is Won Kim, who is just a terrific guy. We've referred other people to him and they like him. He was mentored by Larry Fong, and I think you'll find he speaks fluent BRCA.
Very good.
Why, what is it about his background that makes you think that's the case, Rick?
Because he worked for, he came up through Larry Fong's lab, and Larry is probably the best genetic medical oncologist, GU medical oncologist at UCSF.
Yeah.
So why not Larry?
Because you can't get to Larry. Larry is the co-director of the new Immuno-Oncology Center, and he's not taking new patients. And the only way to get to him is if you get admitted to a trial right now.
So, Jim, this can get pretty complicated. And there are very few medical oncologists that are familiar with the genetics of prostate cancer, and especially with the role of BRCA mutations. Is your mutation in BRCA1 or BRCA2?
BRCA2.
BRCA2, yeah, okay. So I think that Rick's advice, to sign up with this fellow is really good. And, they'll be able to point you to the right drugs and the right clinical trials for some of the newer versions of these drugs. And they really, someone like the person that Rick is suggesting will know much more than most other oncologists.
Right.
So there's that. And then, you should feel free, we can talk about this more when we talk on the phone later this week, but, you should feel free to get in touch with me with any questions that you have. There is, I don't think there's anybody that knows that knows more than I do about this stuff. And so I can help you, but both in terms of my training and in my experience as a BRCA2 patient. So if you have any questions, you should feel free to get in touch with me.
I have a question. I have a question for you, Bill.
Sure.
So if you know that you're BRCA positive, BRCA2 positive in this case,
yeah,
and you know that your disease is in an early stage of recurrence, have there been any protocols or any tests that would indicate when you start treating with that BRCA positive diagnosis in mind? I mean, how early would one start a PARP inhibitor, for example?
I don't think that there's a solid answer to that question yet.
Mm-hmm.
There are some oncologists that are treating with PARP inhibitors earlier than others. There's initially, I think the general consensus seemed to be that it was wise to leave PARP inhibitors, to go with, conventional chemotherapy, for example, first before treating with PARP inhibitors. I probably was one of the very first patients anywhere that was treated with a PARP inhibitor before going through conventional cytotoxic chemotherapy. And it worked well for me. And it appears to be the case that there are now a number of oncologists who are using a similar strategy to treat their patients. But there isn't at this point, there's just so little experience.
What was your PSA when you intervened with the PARP inhibitor, Bill?
I think it had gone back up to about 12.
Okay.
So nadir of about 0.3.
Okay. Okay. Well,
Bill?
Yes.
I'm sorry, Rick. Bill, do you have to be in a trial to use a PARP inhibitor, or can an oncologist prescribe it now? Is it a like olaparib or pembrolizumab? Do you have to be in a trial to get it, or can any oncologist prescribe it?
I obtained both of them without being outside the context of a trial. So
well, you have special connections, though. I mean, you know everybody that matters. What about a regular guy like me?
Yeah, but Dominic also was on olaparib and outside of a trial, and he had no connections.
And I've heard of other patients, that have not had connections. But it depends on the oncologist, and some of them I think are under the impression that it can only be obtained through a clinical trial. And so, anybody that's listening to this discussion and, and encounters an oncologist who refuses to treat with a PARP inhibitor, for example, or some of these other drugs outside the context of a trial, may need to, stick to their guns and demand that they receive that treatment.
But Bill, in any case, don't you need to be metastatic castrate resistant, at least in order to be insured for your olaparib treatment? You're not going to get insurance if you're not MCRPC, correct?
Yeah, exactly. Yeah, that.
Yeah, and it's a very expensive.
I don't know of anyone that's getting it without being metastatic and castrate resistant. You're right. There may be. I mean, that doesn't mean there aren't patients in that category, but I haven't heard of any. I mean, it's worth emphasizing that this is all new. 4 years ago when I began my treatment, or 3 years ago, 3.5 years ago, no one in the urological oncology field, I shouldn't say be that categorical about it. There were very, very few oncologists who knew about the connection between BRCA and prostate cancer, or knew very much at all about the genetics of prostate cancer. So, it's a rapidly evolving field, in part because it's so new.
And to find out if you're BRCA positive, you have to take one of the germline tests, correct?
One of the DNA tests.
Yeah, correct. They need to sequence your DNA to look for mutations. But as we were talking about a little while ago, once you're metastatic, it's important to look for mutations in tumor cell DNA too, even if you're not germline positive. I mean, for reasons that I'm not sure anybody understands yet, mutations arise in BRCA genes and other related genes much more frequently than anyone expected, just in the tumor spontaneously. So it's important, to sequence those genes looking for mutations too in the tumor cell DNA.
So, Jim McCoy, we've given this a little bit of an airing. If you would like to pick it up, send me some times and we'll do a one-on-one with you, with myself and Bill. Just for the benefit of those on the call, I think most of you know, but just in case you don't, these calls are all free and drop-in. If you want personal navigation from any of us at Answer Cancer, at AnCan, it's always available. We do ask you to make a donation if you want our time. And we have a recommended rate, but no one is ever turned away. So that's why I invited Jim. Jim had indicated actually before the call that he wanted to talk to myself and Bill. But Jim, if you'd still like to do that, if you want to dig down some more, then just let us know. We're happy to arrange something.
Thank you. I will be doing that and intend to dig very deep.
Okay. All right. Well, I don't think there's anybody who's got as good a flashlight if we're digging deep than Professor Bill Burhans. When it comes to this particular subject, as he said, he's educating his principal and his investigators right now, and that's a good segue, Bill. Just give us a quick 5-minute update on where you are with your trials and what happened with your PSA last week, because it's really fascinating.
The trials and tribulations?
The trials and tribulations.
Okay, so just very briefly, when I told you guys about what was going on a couple weeks ago, I think it was probably about 3 weeks ago, I was getting ready to enter a clinical trial that would test the efficacy of a drug called AZD6738. And this is a drug that inhibits a protein called ATR, and ATR plays a key role in a genetic pathway that my laboratory discovered back in 2003. We were the first lab to publish on this pathway. So my description of what was going on that I gave you guys 3 weeks ago, I think I told you how there was I was getting disparate recommendations from my 2 oncologists, one who was at Roswell Park, where I work and where I'm being treated. And that oncologist, so I need to tell you that I have been for about 2 months being treated with Keytruda or pembrolizumab, which is immunotherapy. And it didn't seem to be working in the sense that my PSA was skyrocketing with a doubling time of about 3 weeks. And I had gone from a couple of metastatic lesions 6 months ago to too many to count. And then my new oncologist at Dana-Farber, where this clinical trial it's one of the locations where this clinical trial is being held, was arguing that the Keytruda was not going to work because we hadn't seen any effects yet. And I'm realizing I'm not being very articulate here. My oncologist at Roswell Park, on the other hand, thought that we needed to give the Keytruda more time. So that's the important thing. These guys disagreed, and I went with the recommendation of my oncologist at Dana-Farber in Boston to drop the Keytruda and enter this clinical trial. So I have been making frequent trips to Boston. I've been flying there at least once a week over the last month to prepare to enter into this trial. And last Wednesday, I was given my first canisters with a medication, and I entered the trial. But as I was taking this medication for the very first time, I was literally lifting it to my mouth. My oncologist was sitting next to me looking at a computer screen, and he turned to me and he said, "Bill, your PSA has dropped from 48 to 40," which means the only explanation is that the Keytruda was actually working. So, so it's just, it's one of those really crazy things that I think we all know about that happens when you are dealing with cancer. It's just, in some ways, it almost becomes absurd. But in any case, it's not a problem. I think that this drug that's being tested has a great deal of promise, as I said 3 weeks ago. And this was my only opportunity to be treated with it. And so, I think I made the right decision. The Keytruda, on the other hand, I can get access to at any time outside of the context, including outside the context of a clinical trial. So if it turns out that the ATR inhibitor doesn't work, then I have the Keytruda to now to fall back on. So it's all good, and I'm feeling. I mean, my oncologist at Dana-Farber told me about 3 weeks ago that if we could not slow progression, he said, then you need to finish writing your science papers, meaning that it would not be a long time before I would be gone. And now all of a sudden, the horizon of my mortality has been extended significantly. So I'm very happy about all of this.
And so may I add, are we? It was great.
I appreciate it.
For sure.
So would anybody like to just ask Bill any questions before we move along? About trials, pembrolizumab, et cetera, et cetera.
This is Bill Franklin. I want to ask Bill a question from a professional status. Are you familiar with the right to try law that was just signed that the president just signed?
Yeah, a little bit, not completely.
Yeah. So right to try is basically a lot of states will give patients the right to try a drug because of what we just talked about the being in a clinical trial or not being a clinical trial.
Right.
And it has some restrictions, but it's not always good for the patient because it opens up the door for, basically snake oil peddlers who haven't gotten a long way into the testing process.
Right.
Past phase 1 or phase 2 or whatever. Basically, if it's past a phase 1 trial and has an IND, then someone who's terminally ill can try it if they think it might help their disease.
Right.
A lot of people don't like it. A lot of doctors don't like it, but legislators are not doctors, so.
Right. Yeah.
And I was wondering what your professional opinion is on right to try.
I have reservations about it too. I mean, what you don't want is for a patient to be jumping from drug to drug.
Right.
And for a variety of reasons, but including the fact that, you need to give drugs time to have their, to see whether or not they're going to be effective, as I've learned in a big way over the last couple of weeks.
Yeah, the only bright spot I saw is for people like us is, as we were just discussing, if you could get a drug only in a clinical trial, but it's past phase 1, then a right to try law gives guys like us we want that because it's been shown to be promising. But at the same time, sometimes insurance won't try for right to try. It depends on your insurance company. So you might costs will be out of pocket.
Right.
Yeah, that's
And
what I was wondering about
I
was
guess-
the insurance coverage.
I even read one article where the insurance company said that not only is your cost out of pocket, if you incur some sort of complications for trying this drug, that's out of pocket too, because they're not going to cover you.
Right, that's right. I read that
So
too.
insurance
But
companies trying to protect themselves.
Right.
I think, you know, some people involved in this debate are also saying that it's not really necessary because a lot of drug companies are already making drugs available
Right.
for terminally ill patients on a, you know, compassionate care basis. And
There's actually an FDA program called Expanded Access Program
Right. Yeah.
that will allow you to access these drugs without going on a clinical trial.
right.
And they have a pretty high approval rating, from what I understand, around 98% or so that they approve.
Yeah. Yeah. I mean, this was how I was able to get olaparib, the PARP inhibitor. You know, was you know, I told my oncologist that I wanted to take it, and they wrote a letter to my insurance company justifying my taking it. But, you know, with the understanding that the data just weren't there yet to really support, you know, the use of this strategy. But they approved it anyway on a compassionate care basis. And you know, and there was some evidence. I mean, I did have the BRCA mutation.
Mhm.
So, but
There
I
is
did,
there is a subtle difference here, though. I think you know, compassionate access has been available for some time, and I've worked with guys over the last 5 or 6 years where occasionally we've tried it. But a lot of times, the compassionate access are for drugs that are already FDA approved, and people want to try them off label for a different disease.
Yeah.
We know that that drug, we know that the dosage of that drug and the nature of that drug is not necessarily going to harm you. The problem that I see with right to try is that it's giving people access to trial drugs that have not yet been FDA approved. They've been FDA approved for clinical trials, but we don't know the impact of those drugs yet. We don't know the impact of the dosage if they're only phase 1, and that's a difference between the expanded access, compassionate access, and the right to try.
Wasn't one of the factors that it said you had to have already gone through all the normal channels and there'd be no options left before you had the right to try? So if you get to that stage, you might be taking a 95% shot into the dark that anything is going to be useful. But if you've gone through everything and you're at that desperate stage right before hospice or something, or final chemo, as I call it, in hospice, then you would have to reach that point before right to try would apply. I don't know if I'm 100% correct, but I think that's a factor.
I think you're right. I'm not certain either, but the bottom line is, Rick, you know, olaparib was not approved for treatment of prostate cancer.
Correct.
And
But it
so,
was approved for treatment of ovarian.
right. But it's, you know, men are very different physiologically from women. And,
I can't argue with you. Can't argue with you, Professor.
yeah. But so.
But there was also, Phil, wasn't there also already phase 2 results using olaparib in BRCA positive prostate cancer patients showing efficacy, even at the time you took it? So you did have that.
I'm trying to remember when those results were published. This is the paper that I know you're as familiar with it as I am from De Bono.
Yeah.
I can't remember whether or not that had already been published when I started treatment. So yeah, I think it probably had been. And so, yeah, that provides some.
We're going to have to move along here. It's a great discussion, and I've got more questions, but I'd like to come back to it if we can at the end.
Sure.
I just want to make sure that I give everybody a chance to speak. I think we lost Gary, which may mean that the Washington Capitals scored too many times, and he's going to throw himself off his roof. I don't know. What's the score there, Rich Jackson?
End of the first period is 3-0 Capitals.
Oh, terrific.
I think that's why we lost Gary. He didn't want it.
He needed a refill.
Yeah, he needed a refill. He'd had enough bad news there. He may come back.
He needs a refill on his huckleberry wine.
So,
Okay.
Rick, the other thing is, as you know, I love to lecture. So, I mean, you should cut me off.
Okay.
Yeah.
We will
Hey,
cut you off. Rely
I'm
on
sorry
the
I got him
moderator.
started.
That's right. Rely on the moderator to offer the time. Okay, let's go to Jeff Marchi. Jeff, you had a couple of questions for us.
Yeah, just one thing. You were talking about, was either last week or the week before, testosterone levels, and you were saying that they should be below 20. And mine, well, I got it a couple days ago. This was finally hit 20. Usually it's 22, 23. Is this something to worry about, or just forget it?
But again,
what would you do anyway?
Okay,
It's close enough to the threshold. I don't think you need to worry about it.
All right.
We can't give you medical advice on this call. We can talk to you from our own experience. So let me just give you a couple of little anecdotes that might be helpful to you. Up until probably 3 or 4 years ago, the criteria was less than 50. When I was diagnosed, the criteria was having a testosterone level of less than 50 ng per ml. And then they started introducing the concept of lower levels, and to try and get your testosterone down to a level of around 20 or a little below 20. And Ken Anderson is actually the expert on this, because he's read all the different papers and the different research, and there does seem to be a benefit from being closer or below 20 than up around 50. But when you are that close to it, and given that testosterone can move around on any given day, you know, it's as I like to say, it's close enough for government work. Who else would like to talk about testosterone level? Anyone else?
Hey, I work for the government, and I agree with Rick.
I didn't mean to offend you, Mr. Franklin. Sorry.
It's all right.
Hi, Rick. This is Rich.
Yes.
I saw an email come through from Us Too. It was on one of their blogs. A gentleman was demanding testosterone test because, based on about 5 different studies, the indications that he had seen as a trend was if you were greater than 32, that biochemical recurrence and castrate resistance occurred like 3 to 5 years faster than if you were less than 20. So one of the things that he pushed for and his oncologist agreed with was he was getting PSA and testosterone tests like every 3 months to verify that, yes, ADT was working, but to help determine when potentially he was looking at BCR. Because there was a magic number that if you were below this, your odds improved markedly, and if you were over this, your odds decreased markedly. And the ballpark was 32 was one of the numbers. 50 is castrate failure, if I remember correctly. If you got like a T of over 50, the ADT is no longer working sufficiently? Is that
Yeah, pretty much.
okay? So the closer you are to 20 or below, the better it is for postponing castrate resistance and in turn, biochemical recurrence was what it was seemed to be indicating.
Well, I have no idea how low my testosterone was because the test only measured less than 50 to a sensitivity of less than below 50. So I would never have known whether I was at 48 or 18. But now most tests measure to a level of less than 20, and if you're over 20, they tell you what it is. But the Kaiser system, which I was part of, measured me every month, and the reason they did that was really out of cost control because they were giving Lupron based on your testosterone level, and so they were trying to save themselves money. But I know a lot of people don't get measured on a monthly basis. Anyone else have anything to say on testosterone?
This is Jeff, by the way. I have Kaiser, and they were actually having me take tests every 30 days for the last year and a half.
Right.
I switched it to 45, but I get both testosterone and PSA for the same $35.
Right.
But it's the other thing I just wanted to give you an update on the on getting well, it doesn't really matter.
I have a question for you, Jeff. Have you gotten any acupuncture?
Well, the deal is, I asked Harstech, and she says they don't do it in Oakland. They have not enough numbers to make it effective. So I asked my guy, Martinez, and he said he put in for it. He says, let me know if they get back to you. And they did not, and that's been 3 weeks. So apparently they have the same attitude, because with Kaiser, as you probably know, if you are recommended for something, you hear from them a day or two later. They don't screw around. And I have heard nothing. I also did some research on the web, found one study where they had acupuncture with electrolysis, sham acupuncture, acupuncture without electrolysis with a liquid, with acupuncture with just plain without anything, and then how they could is placebo. And they found that acupuncture with the electrolysis worked in 8% of the cases for prostate people that had the hot flashes, but the sham acupuncture worked in 6% of the cases. And what that is where they do acupuncture, but they put it in the wrong spots. They put the pins in the wrong places.
Mm-hmm.
And I don't know what the heck a placebo is, if that isn't, but the placebo was almost nothing. But I haven't heard anything. I happen to find that one on the web. I'm going to check back with them and see if they've got actually an answer for me. But thank you.
Okay. Well, what I would suggest is call the ombudsman at your local Kaiser and pursue it through the ombudsman and see if you can get an appointment with the Kaiser acupuncturist that does exist. And failing that,
they do have it.
Right. So that's what I would push for.
All right.
Okay.
I didn't know of that. Thank you.
Okay. Did Gary come back to us yet? Did he return? No. Okay. And I see, Les, did you want to talk? Did you want some time to talk about your situation today? Les, maybe it's possible that it shows you have a microphone. It's possible that it's not working at your end.
I also sent him a private note, and he didn't respond to that either, Rick.
Yeah. Well, anyway, so we've got enough other people, so but I want to make sure I cover everybody.
And caller 4, whoever that was, dropped off.
Yeah, I saw that. And Jim was on for a second. I think that might have been Jim Kubat, but he didn't stay on the call. Peter Kafka, you're up.
Yeah, I want to give Bill a chance to lecture here. I wanted to come in before when you were talking about your situation. And this applies a little bit to Keytruda when you were speaking about using that. I keep reading and rereading and trying to understand, but I'm still at a loss. And I wonder if you could give me like the 5-cent simple explanation of what microsatellite instability is. I just can't wrap my head around it, and I don't understand it.
Okay. It's actually, I think I can do this in a way that will make it understandable. So satellite DNA is a repetitive DNA. So you know about how DNA is made up of A's and T's and C's and G's, right? And so satellite DNA will be a run of A's and T's, for example, AT, 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 AT. And so that's defined as satellite DNA. And if you have mutations in certain proteins that are involved in replicating DNA, it can cause mistakes in that type of sequence that leads to the expansion or contraction of these satellite DNA sequences. So, if it was 10 ATs in a row, it might grow to 20 or 30, and sometimes it shrinks. So that's what satellite DNA is, and microsatellite instability. Actually, it's microsatellite is a category of satellite DNA. So microsatellite instability just refers to that expansion and contraction. And when it happens, that means that almost certainly you have a mutation in one of these proteins that's required for accurate DNA replication. And that in turn means that you have a hypermutation phenotype. So you accumulate lots of mutations, not just in microsatellite DNA. And that makes it easier for the immune system to recognize your tumor cells and to infiltrate solid tumors. So if you have microsatellite instability, it's basically a marker for a hypermutation phenotype. And that hypermutation phenotype can potentiate the action of drugs like Keytruda by making it possible for the immune system to interact more effectively with tumor cells. Does that all make sense?
How do they test for it? How do they test for that? Is that part of genetic testing?
Yeah, it's just when they sequence DNA, they will include a sequence that has satellite DNA within it, and they just look for that contraction and expansion, or both. So it's just another, like other DNA tests that involve sequencing the DNA.
Speaking of which, Bill, have you gotten your MSI results back yet or not?
No, I have not. I was supposed to get them late last week.
Yeah, right.
Yeah, so I'm anxiously waiting.
Right.
I should, that was another part of the picture. I have a mutation in one of those proteins I was just talking about. And the expectation was that I would have a microsatellite instability phenotype.
Right.
So that made it surprising when Keytruda didn't seem to be working.
Yeah.
But now it all makes a little bit more sense.
Yeah. Peter, there will be a test next week.
Yes, right.
Yeah, I'm still having trouble wrapping my head around this one.
And my lab is still open, so it's never too late to become a graduate student.
I mean,
yeah, you think he's going to move from Maui to Buffalo?
Oh, this is a problem. And I'm serious about that. Boy,
Let's go shuffle off.
I've been on a number of search committees over the years, and boy, you know, Buffalo is not a popular place. Even though it's a wonderful place. But if you don't like snow, it's not a place you're going to enjoy.
Peter, did you have another question?
No, that was pretty much it. I still don't understand it all. I mean, you sent out something the other day, dealing with microsatellite instability and so forth. I mean, I know I have a genetic, issue with a gene that's mismatch and a marker for pembrolizumab, but I don't know if I've got microsatellite instability. I have no idea.
Okay, so you tested positive for a marker that suggests that Keytruda would work. Is that
Yes?
what you said?
Yes, correct.
Do you know what that marker is?
MSH6.
MSH6. Okay, so that's a gene that encodes a protein that's involved in replicating these satellite sequences or repairing them, more accurately.
Repair.
Yeah,
Right.
It's involved in repairing the mistakes that occur in satellite sequences when they're replicated. I don't know what was the test, a measure of the levels of MSH6 protein? Do you know?
It was just a genetic test that came back and said this was your mutation.
Okay, so it
I don't
sounds
know
like
I don't know whether I have microsatellite instability or not. That's what I don't understand.
Yeah. So who did the test?
Ambry.
Okay, I'm guessing that they sequenced a region that included satellite DNA or microsatellite DNA, and they saw this expansion and contraction of sequences, and that is microsatellite instability, even if they didn't say that, even if they didn't use those words. But I'm puzzled by why they wouldn't. So why don't you send me, if you're interested, if you want to send me your Ambry report, or at least the part that discusses this, that would help me to give you a more informed answer.
Okay, that would be great. Thank you.
I think, Bill, I think that the regular Ambry germline test does not report MSI. So it's not on the panel.
Yeah.
And that's why it didn't indicate to Peter what his MSI was, because they weren't testing for it. And what I sent to Peter, and I think I sent a copy to you too, was something I read last week that suggested that people that have Lynch syndrome should test for their MSI. And I suspect that's because it would just help to know if you are a candidate for a drug like pembrolizumab, or which is Keytruda.
Yeah, if you have Lynch syndrome, then that is by definition, you have a hypermutation phenotype. And that would, could very well lead to microsatellite instability. I just don't know without seeing the test, and Ambry is the company that did the test for me 4 years ago or 5 years, whatever it was. But I haven't followed. I have no idea what they do these days. But if Peter sends me the report, then I can figure out exactly what was going on.
Thank you.
Fair enough.
Okay, Peter, anything else you'd like to bring up tonight?
No, that's about it. My PSA is staying at 0.12. That's been that way for the last 6 weeks on Zytiga. Hasn't changed. So I'm a happy camper for now.
And how are you feeling?
I'm feeling great. I'm still, I'm working out every day, and yeah, I'm feeling pretty strong and vital. I get tired, but I'm not fatigued at all. I'm tolerating it really well so far. And it's just about 3 months.
Fantastic.
I know Len said the other shoe is going to drop at 3 months.
Well, it did for me. It doesn't mean it will for you.
Right. I know. I'm hoping.
Are you there,
So
Peter?
what was the, I'm sorry, Peter, what was the PSA drop?
Well, when I first went on Zytiga, I was at, when I had my scan, I was at 0.78, and then 2 weeks into Zytiga, I was down to 0.12, and now 6 weeks or 8 weeks later, it's still at 0.12.
Very good.
All right.
Peter, are you taking Lupron?
Yes, I got a second Lupron shot next month. Yep.
Okay.
Okay. So let's move on to Jay Mills. Are you with us, Jay?
Yes, I am.
Good.
Yeah, going up tomorrow to Mayo to meet with Stish the next day on Wednesday. I had met with
Jay, can you speak up a little bit?
Sure. Can you hear? I can switch over to my phone. 1 second. Okay. Can you hear me better?
Yeah, much better.
Now we can. Can you start over again, please?
Yeah. Let me fix it. Let's see. Okay. How's that?
In between, not as good as it was before, though.
Okay. All right. I'm going up to meet with Brad Stish, radiation oncologist at Mayo, on Wednesday, and just planning on doing HDR if my questions can be answered adequately on the morphology of my prostate. I've got a prominent median lobe that I took a urine flow test, and I had a large retention, but it may be because I had really just had too much water, and it was probably backed up in my kidneys when I took the test. That's my main concern is with the urinary symptoms may be too risky with HDR. I don't think so, and I think that I had one discussion with Brad about a week ago that he did not think it was, but I wanted to have a final review with him.
Okay. So you're leaning towards HDR together with pelvic girdle radiation?
That's right.
Okay. And has there been any discussion about, well, I can't remember. Did you get a Lupron shot or you did not? You did not yet.
I have not yet. I have not yet because just because surgery is the other option, and I've been told that you shouldn't go on ADT if you're doing surgery.
And have you had any discussions with Stish about ADT?
Yes, I have. Yeah, it would go on to ADT for a couple of months beforehand, 2 to 3 months before the treatment.
And how long would you remain on ADT?
12 months minimum, but possibly go to 24.
Okay.
If I tolerate it well.
Okay.
He was basing that on the findings of the ASCEND trial and I think more recent studies.
Okay. Okay. I think you got to make a decision pretty quickly because I know we've been talking now since March, since a little after March, I think, and
yep.
And so you unless you take an ADT shot, which would sort of put you in a it would put everything in abeyance, put you in purgatory, as it were. It's probably good to make a decision relatively quickly. Again, that's from a navigation, not from medical advice, but from a navigation standpoint, and what I've seen with a lot of guys over a long period of time.
Agreed.
Okay.
Jay, I have a question. This is Peter. Where did you have your urodynamic testing done? Because usually they can tell whether you're retaining urine in your bladder or not. I mean, with simple ultrasound, they can see how much is retained in the bladder or whether it's backing up into the kidneys. That should be a brainer.
The cutoff rate is about 100, and where there's some concern.
We lost you. We've lost you again, Jay.
Okay.
Now you're back.
Okay. Can you hear me now?
Yes.
Hello?
Yes.
Okay. All right. I'm driving my car, taking it away from. I took the urodynamic test at Mayo and the ultrasound, and the chart goes to 600, and my void volume was 549, and I had my flow, which is good. The pattern was good, but the retention was 135, and it's supposed to be anything above 100 is a concern. Brad said that he felt that was okay though because I had such a high void volume. I just overdrank. I overdid the test, and that that's why he thought that the retention was high, and that perhaps I don't normally retain that much. And so I could after our meeting do it again.
Peter, does that explain what? Does that answer?
Yeah, I guess so. It sounds like he had it, good. Went to a good testing facility. It just seems odd to me that they couldn't determine, what was they couldn't void that much. But that's fine. As long as they're going to do it again, that's great.
Yeah, I'm going to see if he thinks of doing it again is merited. I hope so, because it just doesn't. When I went to see Paul Newen at Dana-Farber, he had said that my prostate, the median lobe and the general shape of my prostate were worrisome brachytherapy. And but again, he does mostly low dose, which is does have more urinary toxicity, and so that's where my caution has come from. He said you might be better with surgery because from what I've been reading with especially two people have talked to this in their presentations at big meetings. One would be Nelson Stone of Stone and Stock. We've done a lot of work. And also Juanita Crook up in Canada. Both of these folks are very well regarded in terms of the brachytherapy work, and both of them have said that actually the work urinary symptoms you have, the better off your long-term results will be with brachytherapy. Ironically, and yet the standard response is that if you have urinary symptoms that are moderate or severe, that you should perhaps not choose brachytherapy. And I think that's more. There is a time period, of course, where you have brachytherapy where you have symptoms, but it's an increase from wherever your baseline is. But then in terms of your recovery, it just takes a while, and it's patience, as I understand. And you may need to self-catheterize, but in terms of long term, it should return to baseline. And so I'm not sure where the truth lies in that. So I'm not sure how well they can predict it, and I don't know if any of my features are worrisome or not. In truth.
Okay. Well, good luck. Good luck with this. Yeah.
Yes. Thank you.
Did you have any questions that you wanted to ask us, Jay?
I think that's really the main question is if someone started out with, I guess median lobe is one question. The median lobe, I have learned several things. One is that ADT shrinks prostate tissues, but not so much the median lobe. It does shrink it, but not to the same degree. That median lobes persist as something that is obtrusive into the bladder, and if it is very large, it will actually have a crest to it that can actually plug the urethra or the bladder neck.
Mm-hmm.
And I wondered if anyone has on this call, or anyone on this call knows anyone that has had difficulties with a median lobe after brachytherapy.
Well, I guess first of all, I had low dose brachytherapy. Who else on this call has had brachytherapy? Jim McCoy, I think, had brachytherapy. Correct, Jim?
That's right. I had HDR.
You had HDR. Did you have any urinary issues subsequent to your HDR?
Yes, I did. About 2 years after the HDR, I began having urinary burning, burning pee, and it got pretty bad over about a 6 or 8 week period, and just continued. And if you remember John Nidecker,
yes,
at UCSF, he too had Joe Shu's HDR, and he, in a little shorter time than I, had similar experience about 1.5 years following his HDR, where he got burning pee, and he just shrugged his shoulders and said it went on for 6 months, maybe a year, and then it just went away. And I said, okay. So I went back to Joe Shu, and he sent me to Shinohara, and Shinohara did a cystoscopy and looked in and said, everything looks like it's supposed to. You have a little bit of a stricture in your urethra, but not much, and gave me some methylprednisolone, which did nothing. And the bottom line is, within about 9 months, it went away.
Mm-hmm.
It just went away. And if John Nidecker hadn't said that to me, I would have been completely baffled. But apparently it's not rare. to have a period of urinary issues post HDR that just self-resolve.
Well, I guess I've got that to look forward to. I had HDR.
Not all guys get it, but apparently it's not rare.
And have you had any, to date, have you had any issues with your HDR, Rich?
Initial, blood in the urine. We went from 1 flow max to 2 flow max a day, but other than that, stream varies a little bit day to day, but nothing that would be considered painful. So not yet. And
Yeah,
my HDR was the 11th of January this year.
okay, so it's still very recent.
Very new.
I had, as I said, I had LDR and I had cystitis for over the first 5 years or so, 5 or 6 years. I had bouts of cystitis, but it never really bothered me, and it stopped now. So I had to have a cystoscopy, but they just saw some inflammation and what have you. So I'm not sure how helpful that is to you, Jay. But I guess what might be good to put in your mind is that some sort of inflammation is fairly common after brachytherapy.
Right. In terms of the, from what I've read and heard, it sounds like about six months to the worst symptoms, and then it tends to gradually improve over the next 2 or 3 years, and many people return to their baseline. And I wonder, is the baseline back to your pre-ADT baseline, or to your to the baseline where you had shrunk your prostate with the ADT?
Well, I mean, that's a tough question to answer, because if somebody had BPH before they went on ADT, and so they had a bad baseline, and then they basically shrunk their prostate through all of the treatment, they could never get back to the pre-baseline. I think it really depends on what your physiology was before you started.
Yeah. Okay.
And
Jay, this is Peter again. I had urinary retention when I was first diagnosed, and it was complete urinary retention. I was on catheters, but I was on ADT for 8 months, and it never resolved the urinary retention. There was not enough shrinkage to clear things up, so I remained on catheters, and that precluded me from doing any kind of radiation. I ended up having to do surgery, which cleared it up.
Yep.
But I'm not. It's not a good analogy, because I don't know what your situation is or what's causing your urinary retention. For me, the tumor burden was so great that nothing was going to resolve it except surgery.
Gotcha. Yeah, I'm not sure either. The one doctor who said I'd be cautious with this, he said that an obtrusive. He didn't use a noun. He just used the word obtrusive. You have an obtrusive at the bladder neck, similar to a median lobe. And for that reason, I would slightly favor surgery over radiation. And I know I have cancer that's close to the bladder neck. Then I presume just outside of that, I have the median lobe that swings broad at that shoulder and then crests into the bladder a bit. Anyway, I'm not sure that the ADT will. These are questions I'm going to ask the radiation oncologist after tomorrow about that. So I'm not sure if it's the cancer that will be irradiated and the ADT would shrink, or the median lobe that the ADT wouldn't shrink, that I need to be worried about in terms of my urinary. My symptoms are not great. They are, mild to moderate. Now my scores range, the subjective scores between 7 and 11. So it's not great, but this one doctor had said I would worry about this, so I'm checking it out. Okay. Thanks for y'all's time and suggestions. Thank you.
It's a pleasure, and I think our biggest suggestion to you is try to make a decision and get into treatment.
Yes, I'm feeling great pressure for that myself. Thank you.
So let me just check. Les, can you hear us? Are you with us? Are you without us? I do see your microphone on, but we can't seem to connect to you, so don't know. Don't know. I wanted to just check in and see if you wanted to talk to us. I think I've covered everybody at least once. I've got 2 or 3 things I wanted to just raise, and then we'll see how much time we've got at the end.
Rick,
First,
if I can have 1 or 2 minutes at the end, that would be good too. Not necessary, but
okay. The first thing I just wanted to mention is that we're going to try something, we hope, this week that might be very helpful to everybody on the call. I guess I want to say nemesis, but maybe we shouldn't be so evil in our phraseology of go-to-meeting. But our nemesis platform that we are considering changing has just introduced a very powerful function. They provide a transcript of this whole call. So not only can you, rather than listen, you could read through the call, but you can also search on the call by keyword. So, for example, if you put BRCA2 in, that might be more than it could handle because it's kind of an acronym. But if you put pembrolizumab in, you would find where we've discussed pembrolizumab on this call. Or if you put median lobe in, you'd go to the discussion we just had with Jay. And for a lot of people, that could save them a lot of time because they could just look through the calls for what they find interesting. Now, at the end of this call, Jake and I will just do probably a little testing of it to see how it works. Either way, we'll post the call, hopefully within the next 12 to 24 hours. And we'll try and figure out so that we can explain to you how you can use this keyword process. So watch this space. We'll try and let you know, or you'll figure it out yourself, because the link we post may take you to GoToMeeting, and it'll be evident when you get there that you can put in a keyword. So anyway, that was the first thing I wanted to say. The second,
another nice feature of it, Rick, is that actually, on the recording, you don't always know who's talking, but on the transcript it actually says, Rick Davis, Len Sierra, Bill Verhans. It'll actually say who did the talking when it does the transcription. So that's a nice feature also.
Okay. So we're on it. Jake and I are on it, and we've and Len is helping, and Bill Franklin has offered to help. So we're going to be checking this out, the Brains Trust here. Well, I'm not much of the Brains Trust, but the other three guys are. So we'll be checking it out, and hopefully it'll be a really good feature, and it may encourage us to stay with GoToMeeting. We haven't made that decision yet. The second thing I wanted to tell you on everybody on this call, and I'll probably put it into a newsletter coming up, is that I had a very interesting discussion with Dr. Almeida in Phoenix at the end of last week. And as you well know, the regulars, we've had many discussions about gallium-68 screening tests, and we've also had many discussions about lutetium-177 used as a curative palliative agent, a managing agent that would allow you to manage your cancer for quite a bit longer, and there have been some good results. Dr. Almeida is testing an agent that will guide the lutetium to the PSMA, and it's a different agent to the one that's being used in the past. So he's got two trials going on, one for lutetium and one just for screening, and neither of those trials costs very much. So in the past, most people that have wanted to access lutetium, including Rob, who is actually getting his first dose tomorrow, I think, are paying somewhere between $7,000 and $11,000 a session. But this trial that Almeida is running will cost nothing like that. It'll just be a sort of minimal out of pocket. He has filled up the first cohort except for one person. So he's got room for one more person on the first cohort, but they haven't actually started administering the lutetium. They've only done the testing with the gallium to make sure that the people are producing enough PSMA to make it worthwhile and to identify where the mets are. So for me, when Almeida told me this, I felt it was pretty significant, and I just want to make those of you who are on the call aware, and then we will try and spread the word even more. Of course, Almeida's in Phoenix, which means you've got to wrestle with 108-degree temperatures and get to Phoenix. But it's certainly a big advantage over paying somewhere between $7,000 and $11,000 a session, especially when you're looking at 3 to 5 sessions. Okay. Bill, we have 4 minutes, so this is between you and Paul Frieda, who had another question.
Oh, no, Paul should go first.
Paul Frieda. Going up.
Sorry, I was muted. No, I prefer to hear Bill.
No,
I can raise my question next week.
I just have a humorous anecdote. So yours should take priority.
What was that?
Your question should take priority, unless you really want to wait till next week.
Bill, it depends.
Go ahead, Bill. We need something humorous.
Okay.
Yes, please do.
Here's a critical part of the story that I told you about my experience last week at Dana-Farber. And that's related to the fact that I had to give a urine sample, and as part of the pre-screening for the test. And this turned out to be a lengthy multi-hour process, because in order to avoid my bladder, I have to straight catheterized most of the time. And so I was in the bathroom trying to pee into this cup that they gave me for about 45 minutes. And I finally got enough into the cup for their purposes. I should say that I tried 2 times earlier in the day over a total of probably about an hour and a half. And each time I wasn't able to get out enough for what they needed. So this time I finally had enough. And as I was picking up, the used catheter and all this other stuff, I knocked over the cup. And the precious urine was, all over the floor. So at that point, it was like 5 o'clock in the afternoon, and the guys running the trial at Dana-Farber called AstraZeneca, which is the sponsor for the trial, and asked them if they really needed the urine. And they said, no, they really didn't need it. So I thought that was it. But then I came back in the next day, and the first thing they said was AstraZeneca called and said that they needed the urine after all. And so I went back into the bathroom, started the whole process again. So in order to do this, I have to take my pants off. And I also wear an incontinence diaper. And that's why I had to take my pants off, is because I had to take the diaper off. So I'm standing in the stall in the back of the bathroom and with my pants off. And I was just about ready to pee into the cup. And the lights went off. So I'm standing there without any clothes on, or at least from the waist down. And, I didn't want to walk out of the stall to turn the lights back on again, because at any moment someone would walk in and there I'd be half naked. And so I was, I figured that it was a motion detector. And so I started waving my hands, but of course I was in the stall behind this barrier and it couldn't detect my motion. And so finally I was able to pee into the thing. And I think somebody came into the bathroom and the lights went back on at that point. But then I went back out to the clinical trial area and I said, this has got to be one of the most high-tech places in the universe. And in order to get this urine sample for you, I had to use the flashlight on my iPhone in order to see what I was doing, despite all the high-tech stuff. So anyway, I just, they got a big kick out of that, and it was, we had a lot of fun with it.
I'm glad you didn't knock it over again.
So am I. I mean, at this point, I would have done anything to get into this trial. So yeah, I'm glad I did.
That's right. I was expecting a call from Bill. Hey, get on an airplane, come over quick and pee for me.
Or at least help me get my pants back on. Yeah.
Hey, where was your brother when you needed him? Stacking wood, no doubt.
Yeah. He actually was there, but out of reach, out in the waiting room.
I
He
see.
doesn't routinely follow me into the bathroom. I have to say, my older brother is just wonderful.
Yeah.
And he did on another occasion, a couple of years ago. I broke both of my wrists at the same time, slipping on ice while I was hiking in Vermont.
I remember that.
My older brother actually had to catheterize me. And I can't imagine anything worse that somebody would have to do than to
God bless him.
someone else. So that's an indication of how wonderful he is. He was willing to do that.
One thing
Okay.
about this disease, we learn humility, Bill.
Yes, right. And you have to develop a sense of humor.
Yes.
That's critically important.
All right, guys.
Good
Well,
story.
on that note, we will close out tonight, and the next meeting is going to be the 12th, next Tuesday at 3 o'clock Pacific, 6 o'clock Eastern, and everywhere in between. And we'll see how we do with this transcript, and maybe some of you will see if you can give us till tomorrow to get it up, and maybe some of you can try it and tell us what you think of it, and if it's worth staying with GoToMeeting just for the sake of this feature. Okay. Good night, everybody.
Good day.
Night.
Do you want
Good night,
Len?
Gracie.
Do you want Len and Bill to hang on to? Bill
No.
Franklin.
No, we don't need to.
Good
Do
night.
we need
Thanks, everybody.
Ciao.
Night, everybody.
No,
Yep. Good night.
no, I think we're good.
Yeah,
Good night.
Rick, just email me and I'll try to follow the link and see how it works. And if you need anything, let me know.
Yeah, Jake's our coordinator. Yeah, Jake and Len are our coordinators, so we'll be in touch with you for sure.
All right,
Right.
guys. Have a good
Yeah,
night.
thank you for the offer, Bill. I
No
appreciate it.
problem.
Good night.